the world famous Dr. Konior, one of the best in the business. Thank you for joining. Today we're going to be talking about um, repair, which punch is the best, whether an implant or pen or a. Sorry about that, guys. So I'm just waiting for Dr. Konier to join us here. Welcome, welcome. I'm drinking my morning coffee. I don't know what time it is for you guys out there. Welcome, guys. Welcome. I'm waiting for Dr. Konier to join us. There we go. Go. Hey, Dr. Konier.
Hey
How's it
Melvin, how
going?
you doing, man?
Pretty good. Pretty good. So we're gonna have a good 30-minute session here, guys. We have one of the world's best and leading hair surgeons. So, Dr. Konier, I guess I want to start it off by asking you, what are your views on pre-made slits versus implanted pens, and what do you feel is better, or is there a better?
I think it comes down to it's what's best in the hands of the operator. I personally favor stick in place with forceps. I mean, historically, going back years ago, we did pre-made openings, which I believe is more or less the standard of the trade.
Mm,
And over time, I just found that doing one at a time graft placement, making an opening, placing the graft, gave me the ability to be a little bit more artistic in the placement. I think when you go in and you pre-make 3,000 openings, you've already just predetermined how are these grafts going to lay out, what size openings am I using, is it a one size fits all? And when you're doing stick in place, you're basically, I have grafts coming into me one at a time. Our team sorts out the grafts by size, and that size includes how many hairs are per graft, but we'll even then sub segment these things where we'll have larger twos and smaller twos. And so when the grafts are coming to me, I know that I may be getting twos that I'm placing into a zero point 0.7 or a zero point 0.8 millimeter opening. And I know immediately for whatever size graft's coming my way, am I upsizing or downsizing? So in my hands, I get a more meticulous fit for each graft that's being placed. That it on top of that, we're again artistically placing an opening, putting a graft in, so building that hairline or building that coverage throughout the zone. So, I personally believe like a great painting,
mm,
doing individual strokes is a whole lot better than, throwing a lot of strokes on a canvas at one time.
yeah.
So, then you get into the whole debate of forceps versus implanters, which is another debate. And I think the primary purpose of implanters, it all boils down to graft yield, graft safety, graft
Yeah.
integrity, because common sense tells you that the more you manipulate this fragile piece of tissue, the more likely you are to damage it. And there's all kinds of damage that can come to any individual graft. And I mean, probably the number one thing is just desiccation. If you're working in a dry environment, which here in the Midwest we're prone to very dry air in the wintertime,
Mm,
these grafts sitting out for a very short period of time is like a grape turning into a raisin. They shrivel up on you fairly quickly. The second is just the manipulation. How gentle is the graft being handled by the technician or the surgeon who's handling the graft? And ultimately, that comes down to experience. I think when you're looking at technicians in a generic sense, you have to say, well, what's the average technician's experience? How many years have they been in the business? My head technician, who is really the only one who works with me handling tissue as far as the placement is concerned, has been with me for 23 years.
wow.
That being said, I'd personally close my eyes and take a nap if she was one putting grafts on top of my head, because I mean, I've literally seen her place millions of grafts, after
Yeah.
all these years. You place a lot of grafts. So I think if you're looking at the average technician with less experience, an implanter is something that's going to take the human element of touching and contacting this graft with forceps out of the equation. And these forceps are going to crush the grafts. When you're taking that graft, you're trying to put it into a tight opening, the follicle is going to be flipping around, and there's no question you're going to get more injury and potentially lower growth because of that.
Mm.
But when you're doing individual graft placement, where I'm doing this with one person who I know, and I see every graft that goes into a scalp, I mean, literally 100% of the grafts that go into the scalp, I know what's happening at that moment in time. I know if a graft is being bumped. I know if a follicle is being bent.
Mm.
And I can make an immediate call on the adjustments that need to be done. When you're dealing with a clinic where maybe the physician isn't in the room and entrusting the staff, what you
Yeah.
have to say to yourself
Yeah.
as a patient, well, again, how much skill does this technician have, and how much investment does this technician have in me as a patient? And that's a whole nother debate. We can talk for an hour about that.
Yeah.
But I think implanters, there's no question. There's some very highly respected physicians who have gone the implanter route. Personally, I think it's a great idea. Um, I still have not integrated that into my practice because I feel very confident with the stick and place
Mm.
technique that we use.
Yeah, I think Hassan and Wong went the implanter route recently. I think Dr.
Mm-hmm.
Wong was telling me. So yeah, it seems to be going that way, but I guess, it just depends on ultimately on what the surgeon feels competent in doing, right?
Well,
What
it's your team. It's what's your paradigm for surgery? Because if you are a technician driven clinic, and I'm not saying that's a good thing or a bad thing, but that's a thing.
yeah.
The implanter, I think, statistically, is what properly used going to give you a very high probability of a better graft being placed versus the average technician putting their hands on that graft. Now that being said, how do you minimize injury to the graft? You make a bigger opening. Like if you're shooting hoops, if you have a big net or a big rim, you and I are going to get more free throws. And as
Mm.
you make that rim smaller and smaller, we're going to start missing more shots. And as you start making smaller openings to get really precise coaptation of the graft against the recipient site, then you're starting to introduce the element of trauma during the graft placement phase. And that's where experience really, weighs in and shows its benefits.
What are your views on using loops to do the grafting surgery?
Well, you're dealing with microscopic tissue. I mean,
So
anybody who has ever looked at a follicle up close as the layperson, if you're looking at this follicle, take some magnification, put a little mosquito underneath a magnifier, and turn the power up. And every time you turn the power up, you see more bristles and you see more facets on the eye, and you start seeing more detail that wasn't present at the power below. And
mm,
as you continue to push it up, you see more. Plain and simple, you see more. So when you're dealing with a microscopic entity, something that's as small as a follicle, and you're striving to get precise placement, to the tune of like a foot going into a shoe. If you're looking at a follicle that's just a fraction smaller than that opening, you really have to be careful. And as you magnify, plain and simple, you see more. So I personally don't see how you can see the detail of a scalp, especially when you introduce the element of extraction, FUE, and graft placement of meticulously dissected small grafts and get these things in, unless you're compensating by making larger openings that gives you a greater margin of error.
mm,
So I just can't imagine that anybody is doing this without loops. And then it comes down to, what's the minimum loop magnification somebody should be doing this with. And like I said, if your paradigm is to use big needles like being done 15 years ago or 20 years ago
Yeah.
versus custom cut blades, well, anybody can get a graft in one of those big openings.
Yeah. Do you think so? What do you think about? Do you think the lateral slit technique has allowed for greater density? Do you think that that's
I think packing allows for greater density. I mean, what the orientation of my cut, whether I'm making that cut in a fashion like this or in a fashion like this,
Mhm.
I'm still making a cut. I'm putting a graft in. So let's just say density comes down to like pixels. How many pixels do we have per square inch or per square centimeter? And density, how many hairs do we have per square inch or per centimeter? Now, the orientation of those hairs, that's a whole different thing. That doesn't change the density in per se in terms of what's the absolute number of hairs in this zone. But what it does is it can change the orientation of the hair. And then you get into the whole concept of the illusion of density that everybody talks about. Because in
Yeah.
reality, there's no surgeon on planet Earth that's restoring 100% density in a single session. And if they are, I'd sure like to visit and see how they're doing it,
Yeah.
because I certainly haven't been able to achieve that. And that being said, we're most often limited by supply. The vast majority of guys we see in our offices have advanced degrees of baldness, meaning we're not seeing the class ones and class twos. You're seeing people who have a lot of baldness, and that being said, there's only so many bullets that you have in the donor area to use.
Yeah.
And so how we strategically place these grafts to create the illusion of density, like a magician, I tell patients, we're trying to make a little look like a lot. And that comes down to the placement. And certainly when you're doing lateral slits and you're using angulation of the hair as it relates to the skin surface, it hides skin more efficiently.
Mm.
But
Yeah.
packing, in terms of density, again, it comes down, what's the absolute number of openings I'm making? And then the illusion comes, what are the contrast characteristics? Dark on light, light on light, dark on dark. What's the texture? So there's so many factors that come
What's the
into the end
thickness?
result. There's so many more factors than the absolute number.
Yeah.
I always, I won't even say it's amusing anymore, but the number of guys who get, what are my numbers? How many ones, how many twos, how many threes? And I said, well, unless you can really correlate the contrast factors that are going on to your head, factor in texture, and probably most importantly, in my opinion, factor in caliber of hair, which is an exponential benefit to increasing hair shaft diameters for producing density. Those are some components that add up to the end appearance of density. So the number is just one component.
Yeah. Yeah, and that's what people get hung up on, a number. And sometimes you can give a number, like two people can have the same number, right? 2200. But
Absolutely.
how it's going to look can differ vastly based on, not only just the number, the texture, like you said, the skin to color contrast. So, and even the way that the surgeon is going to place it, right?
No
Placement of
question.
the grafts is super important. People don't really realize that, you know.
Well, you do see results on the forum. How often do you see these results where there's a fairly substantial number of grafts that have been placed, but the results just aren't there? Again, whether it's failed growth or just that there's no appearance of density or coverage because of, like you said, placement that just doesn't make sense.
Somebody asked, does a larger FUE extraction yield a larger scar? Is there a really big difference between a scar from a 0.8 millimeter punch to a 1 millimeter punch?
Well, I think that's a more complex question than it may seem to be. But again, as you increase the diameter of a circular shaped opening, you're getting an exponential increase in the area of tissue that's been removed. And there's the pi r squared effect. So when you double the diameter of say, you've gone from a 0.5 to a 1.0. You're quadrupling the size of the opening. That being said, you now have a scar that's going to be, in theory, 4 times the size. Now, the scarring is a bit more complex because everybody heals a bit differently. We tend to see these openings contract down by something secondary intention healing. And then there is also what appears to be some collateral effect on the healing, meaning you can get some hypopigmentation or loss of pigmentation that extends beyond the actual scar itself. So, I mean, obviously a 4 millimeter punch from the era of the old plugs, 1960s, 70s, left a 4 millimeter opening. Now we
Black
just
and
did a big
Decker
repair
punches.
during last week on somebody who's, when you look at this head shaved down for FUE, there's no question this guy's got circular punches. They're massive.
Yeah.
Is there a big difference between a 0.8 and a 1.0? At the end of the day, there may not be. If you're shaving your head, you're probably going to see it. If you're wearing your hair longer, you're probably not going to do it. But you still, for the number of guys who focus in on the number, you still have to say, am I using a 0.8 millimeter punch and getting a lower quality graft? And if I am getting a lower quality graft, I need to use 1.0 millimeter to get the high quality graft. What are you looking for? Are you looking for a great hairline? Or are you willing to grow your hair another 1/4 inch to hide maybe a bit more perceptible scarring? But there's no way to clearly answer that definitively.
That was going to be my next question: is do you feel that the quality of the graft differs from a 0.8 to a 1 millimeter? Because
no question. Well, look, absolutely. There's no question. So when I'm extracting grafts, and again, the tech who works with me with planning works with me on extracting. And when you're looking at something that is essentially skeletonized down to pure follicle, you're looking at this again, fairly small entity that is literally just a follicle. Now, when you get into this whole discussion about placement and trauma and implanters and dehydration, now we know that having a little bit of a buffer of fat around there gives you some extra protection. And so you've heard in the past chubby grafts and skinny grafts when we're doing strip dissection, and how much do you take those grafts down? And again, there's so much involved in there. Who are the technicians? How good are they cutting? How sharp are their scalpels? But I think you have to look at on a case-by-case basis, because a 0.8 on you and a 0.8 on me may be yielding completely different grafts. There's no question. If you look at somebody with afro-textured hair, where you've got these widely curled follicles, trying to take that out with a small punch, you're going to be seeing more transections. So, like the placement, when we're extracting, we're looking at grafts one by one. We're getting a sense, well, these grafts are coming out and they're really looking thin. As you go smaller and smaller, you may have a 2-hair graft. That as you start stripping that fat from around the graft, you start to see that there's more separation of those follicles, where rather than having 2 follicles that are contained by a perimeter of fat holding them together, when you've stripped that down, all of a sudden these 2 follicles, yes, they're connected as a graft, but they're floating around. You've stripped away all of that surrounding interstitial tissue. I think as a surgeon, you'd like to look at this entity that we know is going to depend, the integrity of which is going to depend on the end result coming from the integrity of that. So there's no looking at this graft saying this is absolutely a great graft, but when a graft is poor looking. I mean, there's no question about that. Yeah. And I'd rather move my punch up 0.1 millimeter to assure that I'm getting a higher quality graft. Because how many FUE cases have you seen in your career that have low yields? Where's that coming from? Is it originating from a bad extraction? Is it originating from a bad placement? Because there's multiple areas along the pathway to put extracting and placing where you can have that problem arise.
So there's always been emphasis on the extraction and not so much as the placement. So I think you bring up a pretty interesting point. So you're saying is that low yield can come from poor extraction and also from poor placement. Usually people don't put that much emphasis on the placement, but the handling of the grafts is essential
Yeah,
because
it's absolutely essential. Again, if you were to just do a little time lapse video of a graft that comes out and you lay that on the side and you look at how fast that graft dries out, it doesn't take long. It doesn't take long at all. And then again, you get into the crushing effect. As you skeletonize a graft down, here's another point. As you go to the smaller punch and you get this smaller graft, and you've lost the surrounding cuff of fat, and you're just dealing with pure follicle. Now your technician's coming in, and if they're handling that with forceps, they're more likely to be grabbing the living entity, the follicle, because there is no fat to grab. And here again, you get into the crush component. So if you're going to be harvesting small grafts and you are taking these things down to the nth degree, implanters make even more sense at that time because now you're taking the handling of the graft away from the technician. I mean, somebody's still handling it to load it,
yeah,
but in theory, that's a much easier process than bringing it into a small slip.
yeah, yeah. That I mean, it makes sense. The implanters removing an additional step for technicians. So let me ask you this question, and I think this is one of the most asked questions. What to you is the illusion of density?
The illusion of density, again, is like I said, trying to make something small look big. It's David Copperfield.
Yeah.
I've got a mouse here. How do I make it look like an elephant? Here's how I tell patients. It says, what's balding? What's thinning? Thinning to me
I
is more
actually
about.
said that to Dr. Charles. I
Oh,
used to
really?
quote.
Yeah, I said thinning to me is seeing skin. I said if you see skin and you're primarily seeing skin adjacent to an area where you don't see skin, you know that there's an imbalance. I had a patient in here today. We did FUE on him a few years back, and as I'm looking, he's wearing very short hair. What's one of the reasons guys start to cut their hair short? Because as you cut shorter and shorter, now you're seeing skin in the donor area and you're seeing skin in the thinning zone, and so it's less apparent.
Yeah.
Whereas if you have thick hair on the sides and you have thin hair on the top, you say there's an imbalance.
Balance.
So what's that illusion that we're looking for? Saying, how do I take something that's a little in amount, quantity, and make it look like a lot? How do I make a small amount of hair more effectively hide the skin? So again, if you take someone who has very fine straight hair and they perm their hair, they go for a curl. Just a curl alone is going to create an illusion of more density because you are hiding more skin just by using texture. If you see a patient who has thinning or in say older technology mini grafts with very pasty white skin and very say coal black hair, those grafts stand out like a sore thumb because there's dark on light. Those patients, I'll say, don't dye your hair. You want your hair actually to have some shades of gray, variable shades of gray, because you're starting to break up the contrast that exists. So, again, why do you use a lateral slit? When you take 20 Q-tips in your hand and hold them vertically over a surface, the surface representing the scalp, and then take those 20 Q-tips and lay them down over the surface. When you lay them down, they're hiding 20 Q-tips worth of surface. When they're standing, they're hiding nothing except the point of the Q-tip. The point being, by just changing the orientation of that Q-tip to the table or the hair to the scalp, you're creating a shingling effect and you're hiding more skin. So you're intentionally placing grafts using specific angulations with the goal of naturalness, because you want natural hair exit angles, but also hiding more skin.
Wow. I'm going to use that. I mean, the way you put it, and I said it to Dr. Charles, is like, what is thinning? Thinning is seeing scalp. If you don't see scalp, you're not thinning. So that's
why does Dermatch and Topic work? What are you doing? You're not adding more hair. Let's say your hair color, your skin color, and your thinning. By putting Dermatch on your head, you're taking your light skin and you're making it dark, and so you're creating less contrast between the surface and the hair. What are you doing by putting topic on? You're putting these little charged particles onto your scalp, and you're in theory increasing, say, the girth. You're making the trees in the forest bigger.
Yeah.
Thereby, you're also hiding more skin, like the forest. A forest
Yeah.
that's mature, you see less into it than a young forest because you just have more girth around the trees. So, yeah, how do you utilize your tools? The tools we have are the graphs that are handed to us,
Yeah.
whatever they are, 1 hair, 2 hair, 3 hair, fine caliber, thick caliber, curly. How do you take each one of those and how do I most effectively hide skin? Part of it comes from density, part of it comes from the distribution, the gradients, and the different angulations that you're using.
And I wanted to ask you one question about the crown specifically. I was talking to Dr. Wong, and I believe that both of you guys are now in the running for top crown guys. He mentioned that he really likes to put emphasis on the density on the swirl because
Yep,
as it grows out,
agree,
it
agree.
shrinks.
I
So is
totally
that
agree.
your
I mean,
fault?
so again, here we get into this illusion of density. There are certain facts that you have to understand. One fact is that layering hair will always look better than separating hair. So if you take someone who has a part, I can tell
Yeah.
you in my experience, and I graph that hairline equal density across.
Mhm.
95% of these guys come back a year later and go, hey, doc, things are looking good, but I think this side looks a little bit better than that side. I don't think this side took as well. Well, they're always looking to the part side, and
Mm.
that's because the part side is separating. So, we get into the illusion of coverage. I always say if you have a guy who's completely bald and he's doing one of these comb overs from right above his ear, he's
Yeah.
layering hair on top of his head. And if you layer your hair, there's been some famous people who do these crazy comb overs. If you layer enough hair, you hide skin. But we, as a society, know that somebody parting their hair 2 millimeters above their ear is doing something weird. And we know that even though they're hiding their skin, we know there's baldness under there because
Yeah.
it's not natural looking distribution of hair. So getting back into your point about the swirl, if you look at the center of the crown, hair has direction. Every hair on your head or my head has direction. And my hair parts from left to right. My cowlick and my crown is in the back side of my left. And if you look at how the hair on my head moves, it moves from my left side gently over to my right side. So hair on the right side of my hairline has more orientation this way, where this hair at the part actually is like this. So when you're looking at the crown is a point of natural separation. If you put loops on and you go and you look in the crown, there's going to be a point where you're going to see two hairs that go in opposite directions because there's a transition. There's hair that has to turn down in the back and turn forward. And if you had hair that's just going forward and back, you'd have a part. And that's not natural in the crown. So in the crown, as you see the swirl and these two opposing hairs, they start to spiral away from each other. And as they spiral away from each other, hair then starts taking on a more regular pattern. Well, knowing that the center of the crown, hairs are all moving away from each other, that's a natural point of separation. So my concept of the crown sounds like it's similar to Dr. Wong's. I know this is a point of separation. I know I need to get more density in this area.
Mm.
And in areas where I start to see more layering, say like the back of the crown, I
Yeah.
can pull my density back because I know that a little bit of hair is going to be hanging, shingling over, and hiding more skin. So, but there's no question you have to attack the center of the crown if you're looking for a nice end result in the crown.
Mm. Yeah. And I think it makes sense because when it grows out, I mean, you have to think it grows in a clockwise or counterclockwise pattern. So when it grows out, and it grows out flat, which is another thing that the reason why people, and I asked him, like, why is it a black hole for graphs? And he actually said that he doesn't think it's a black hole. He thinks that you can get a good density now with 2,500, 3,000 graphs, but the way it grows out makes it so that the skin is more visible because it's flat. It's not like you said, like when you're holding Q-tips like this, you're going to see more surface area as opposed to when it's all laid on the table. So do you think that that is one of the complications or one of the issues with restoring the crown is the simple way that it grows?
I wouldn't say that it's simple. I think crowns are really complex. I like crowns because I find them challenging.
Hmm.
I believe that the concept of black hole, I think of that from a different perspective, perhaps, than how you described it. My concept of the black hole is plain and simply this. When I look at a man, especially a young man, I have to think, where will this young man be when he's an old man? I saw somebody, I think, on the site the other day, am I a class 2.5 or a class 3? And I'm thinking to myself, really, where do you come up with these ideas? Because if you're a 2.5, you will be a 3, and if you're a 3, you're eventually going to be a 4, and if you're a 4, you're someday going to be a 5 if you
Yeah.
live long enough. So you still come down to this whole thing that if you're balding in the front and if you're balding in the back, and you're going to be an advanced pattern, and let's say you're a lucky advanced pattern of 5, for you to pour it, the guy who's got the 7, who has just by
Yeah.
far much more need than he has graft availability, you're still dealing ultimately with this limited supply of grafts. The problem, the way I envision the black hole concept, though, it's a simplistic version. Let's say you have a young man, and that young man presents to you with a 2-inch diameter circular bald spot in the crown.
Mm-hmm.
At that point in time, you calculate his surface area, and you figure how many grafts do I want per square inch or per square centimeter. Here's my graft number, whatever that may be, at a 10% density restoration or a 50% density restoration. But that young man who presents to you with a 2-inch circular crown spot someday is going to have a 4-inch spot. Now, when that spot goes from 2 to 4, again going by the Pyre square concept, you've quadrupled the size of the zone. Day 1, I need 1,000 grafts to get my objective density. When he comes back to me, he needs 4,000 grafts. So this crown area has the tendency to consume a large number of grafts as time goes on.
Mm-hmm.
I think when you look at any given crown, if it's a manageable crown and the grafts are there, yes, you can do it. But when you start looking at the 5s, certainly the 6s, and definitely the 7s, you say, well, how am I really going to cover this crown? I don't have the supply. And unless you have generous body sources or the ever elusive cloning concept, tissue engineering concept comes along, you still have to deal with what you have available to you.
Yeah. Well, what do you, how can I ask this? What do you think about combining both strip and FUE in one procedure? I know that your colleague and friend, Dr. Gable, has actually done this before as a couple of guys on the forum. So he'll do like a small strip and then he'll FUE at the same time. Like, what are your thoughts on that? Do you think that that's maybe a more efficient?
I certainly believe there's a time and place for it, and given the circumstances, it's definitely something that is worth considering. I definitely use that technique, but still you have to say to yourself, what am I being dealt at this point in time? Am I taking a fellow who we're doing 3,000 grafts on, and he's an ideal candidate for a strip, or am I taking somebody who only needs 1,000 grafts? When are you getting into that need to do that? Well, certain cases, I've had patients who, for example, like to wear their hair short on the sides and wear it long in the back and have great density in the back and are looking for ways to maximize their lifetime graft yield. So, you have to ask these fundamental questions. Am I a guy who likes to buzz my hair to a 1 or 2 all the time?
Yeah.
I'm not talking strip to these patients. Am I a guy who likes to wear my hair long? Or do I like to wear my hair short on the sides? What is my harvest potential? If I'm looking at a fellow and you'll see this where they may have some isolated laxity in the back of their head and their ideal candidate for a strip, but their side of their head has been previously harvested or is tight and you need the graft number, sure, you can combine the different modalities. I think, Melvin, again, it comes down to the Dr. Shapiro's study where he seems to have substantiated that for the guy who's looking to maximize lifetime graft number yield, beginning with strip until you're stripped out, transitioning over to FUE until you're FUE'd out. That's a logical sequence of events. Along the way, there's after somebody certainly has had a strip, there are times where you're going to combine the two harvest modalities, but it's in the individual circumstances. What are you being dealt at the time?
And do you think it can be flipped, reversed? Like if someone's FUE'd out, can they then turn to FUT, or is that doing it that way?
Well, my opinion of it is this. When I look at why am I doing an FUE, excuse me, why am I doing a strip? I'm doing a strip because I feel that here's a patient who has great density, great hair quality, great elasticity in a localized region, the strongest region of the donor area, smack dab in the middle of that donor area. And what you're doing is with a strip, you're utilizing the benefit of elasticity. You're taking your strip out to the limit of safe elasticity. And what you're hoping for in that strip is to take out this conservative strip and have the largest number of hairs available in it. Now, let's look at two guys. One guy has a baseline density of 100 follicular units per square centimeter. Another guy has a baseline density of 50 follicular units per square centimeter. Other than that, they're identical. They have the same elasticity. They have the same healing characteristics. I come in, I take my strip. Strips are identical in both of these guys. Same length, same width because of elasticity, yet patient A has twice the number of grafts because he had twice the density. What is the one thing that FUE is doing to you? It's knocking your density down. You're taking hair out. And if you're taking hair out from the sweet spot of the donor area, you're coming in taking a strip out where the density has already been significantly compromised because of your past FUE harvests. And you've seen pictures as well as I have, people who have supposedly been over harvested. And you look at these pictures and you see more white dots than you see remaining hair. So, what's the advantage of doing a strip at that point in time? To me, you start with strip, you go to FUE, you don't do it the other way around. That's my protocol.
Okay. Yeah, and I personally asked that to you because I was even considering. I was like, what if you just take, because I feel like the most density is right here, right?
Mm-hmm.
Most people say that that's an unsafe area, but for me, I feel like in my pattern, this is
Yeah.
where the sweet spot is, where the best quality hair. But yeah, I mean, I don't know at that point if that would be even something that's viable, just like a side. Has anyone ever asked you for that? Because usually, you do the back, but has anybody ever asked for like just,
Oh, absolutely. I don't buy into that component that's an unsafe area. It may be unsafe for some people, but the nape may be unsafe for other people, and the high occiput may be unsafe for some people too. Still, it comes down to what is this man's final balding pattern? At the end of the day, if we had the great crystal ball that showed us where we're going to be in 50 years, we'd know exactly how to plan somebody out. And you just don't know that. The issue, though, is as you have more and more surgery and as you start to lose elasticity and you're losing density, the efficiency and the positives of strip surgery start to wane. And so I believe the sides are fine donor areas, but again, it's patient selection. You really have to get in there and look at the patient, look at the donor area, factor in age, and all these other things to make a decision what's logical.
yeah. It used to be thought that it was a no-no. Like any doctor that, took a strip up to the sides was doing something wrong. But I don't feel that, especially in my pattern. I feel like that's probably the best place to get hair.
I think I don't know where that's coming from because some of the elite surgeons of the world, the people that I respect who do large sessions and
Yeah.
bring that strip around. And,
Yeah.
again, I look at over my history of 30 plus years doing this, and you look and say, well, where are the problems? Where did I see problems? What were the things that came back to bite me in the butt? And I would just tell you that temple harvesting is not one of them. It's just not. It's just not. Now, if I have a young man and you start to see the indicators of an advanced pattern, I was talking about this a little bit earlier today. Some of the things I look for, I look for miniaturization of the donor. I look at condition of the nape for retrograde alopecia. I look at the temple points, and you start seeing those temple points breaking down. You have to be cautious because those are people who may advance back, where you start to see the rotation of the anterior or forward directed temple point to that temple hairline that straightens out and starts angling back. And you start to see that in certain groups of patients, especially with more advanced patterns. And in those people, it's not uncommon to start seeing increased percentages of miniaturization in the temple area too. So that being said, there are going to be some people, and I'm sure you've seen them in their 40s and their 50s and their 60s and even in their 70s, who have strong hair on the side of the head.
Yeah.
So it still comes down to selecting your patients and doing proper examination.
Yeah, I agree. This person asked, what do you think about purposely depleting the scalp donor to make it look, I guess, homogeneous, and then restocking the donor with beard hair or body hair? Do you think that's a viable option?
I, I don't think anybody should be deliberately depleting a donor area. I mean,
Mm,
that is somewhat illogical. I think we see
yeah,
donor depletions because of poor calculation as to what somebody's donor site has available. But I mean, if your plan is to start restocking the donor area with beard, why not just place some of that beard hair up on top? Why put it in the donor area? Is it that the donor area is a better place for the beard versus the top? I mean, again, when I'm looking at moving hair from other parts of the body, there's a lot of questions that have to be asked. What's the quality of the hair? What's the texture of the hair? What's the color variation of the body area versus the recipient site up on top? And certainly as the color and texture come into balance, body hair is a great source. As they diverge away, then you have to be more careful. But the one thing you want to do is vary the placement. It's like salt and pepper. You don't graft black hair on the right side of the head and white hair on the left side of the head. You mix it together.
yeah,
And the same thing holds true for body hair. I'm not going to take a beard and graft somebody's crown. I'm going to take some scalp hair and move it throughout the entire scalp, and then I'm going to move some beard hair throughout the entire scalp to get a homogeneous distribution. But if you're thinking of depleting the donor area, why not just do SMP? I mean, it's a tough for me to kind of understand the logic of where they're going with that.
yeah,
I think it makes sense when you see an overshoot because there's no question. We've seen overshoots. We've seen some of the robotic problems where there's an overshoot in one area, or somebody who's just gone in for one of these 4 or 5 thousand mega sessions where they're just aggressively harvesting and some of these donor areas immediately depleted. And
yeah.
then in those cases, selective grafting makes some sense.
I think it's kind of come to light because there's a guy on the forum who's had like, I don't know, some crazy like 12 surgeries, and they've all been
Mm-hmm.
small sessions.
Mm-hmm.
So he's had like 12 FUEs, and he's got like, I don't know, 10,000 grafts or something. And so what he has started to look really depleted, and then he actually has some